To start, it's really wonderful to see so many of you here, and I'm particularly excited seeing that program today, which is very much focusing on the basics. What I mean by that is we're going to do the basics of what we do in the clinic, the questions that come up over and over again, and that we really discuss on a daily basis. And then I think it's a wonderful program and speaks very much to the vision of the BC Parkinson's Society, that you're going to look at sleep, at nutrition and mindful living, so all the things that we evolved as human beings to live with and that make us healthy. And I think this really getting these basics right makes a huge difference. So with having said that, what I'm going to do is I'm going to give you a little bit of a background on Parkinson's disease, and then speak a bit about symptoms of Parkinson's disease and how we manage them, with hopefully some practical tips to take home as well. There might be some repetition for you, but as I said, in the clinic, day in, day out, we discuss the same things again, and we try to figure out the same things. So I thought it is worth bringing it to this group again, because that is really our bread and butter. And then a brief touch on research and things that are on the horizon. So as far as background information is concerned, it is now nearly 200 years, to be exact, in 1817, that James Parkinson's published his essay on the shaking palsy, and he described pretty much most of the symptoms that we see in Parkinson's disease. About 100 years later, so this is now the beginning of the 20th century, there was a neurological textbook, and it described Parkinson's disease as a batch of respectable endeavor. And what it said was, PD affects individuals whose lives had been devoted to hard work and who never come under the inhibiting influences of tobacco or alcohol. In this respect, the disease may be almost regarded as a bench of respectable demeanor and endeavor. So in case anybody is wondering about that. So where are we now? Now another 100 years later, Parkinson's disease is now known to be the second most common neurodegenerative disease after Alzheimer's. It is affecting about 1% of the population age 65 and over, and 1% might not sound much to you, but if you think of the thousands and thousands of diseases that there are around, if you have 1% of the population affected, that is actually a lot. And of course, we're all getting older, so this number will just rise. Currently, around 100,000 Canadians are thought to be affected, and about 12,000 people living in BC alone. And again, this number is expected to rise. Males are slightly more affected than females, about 60% males, so 1.2 to 1. And about 10% of individuals affected by Parkinson's are actually younger than 40 years of age. Now, we all know about the motor symptoms of Parkinson's. Those are the ones that are easily recognizable. Those are the ones that other people recognize much more easily than the more kind of hidden aspects, the non-motor symptoms. And so these symptoms, the motor symptoms, that is particularly, of course, the tremor at rest is the one that is typical for Parkinson's, but I'm sure many of you would say, yeah, and I also have tremor when I'm holding things. That can certainly occur as well. Is, of course, one of the main features. Then stiffness, which we call rigidity in medical terms, slowness, bradykinesia, as well as balance problems, which usually come a little bit later, but they can make themselves known reasonably early on as well. What does that translate to in everyday life? And these seem to be fairly abstract terms, but what somebody might observe is, for example, smaller handwriting or frozen shoulder because the arm doesn't swing properly, and of course reduced arm swing, more stooped posture. Swallowing difficulties go between motor and non-motor symptoms. Reduced facial expression, of course, that is often noted by partners who feel that their partner, the affected partner, is not responding to them in the same effective way that they used to do before. But this is a part of the disease. And then, of course, fine motor difficulties such as, buttoning things, etc. And now the non-motor symptoms, and it was already mentioned, I'm particularly passionate about the non-motor symptoms because they affect so many people. I mean, certainly way over 70% of people. I think this is a conservative estimate, actually. I think the actual number is higher. And they can take a shape of actually really many things. Autonomic functions such as constipation, bladder problems, sweating, blood pressure, etc. Swallowing difficulties, again, as I said, that falls into the kind of borderline between the two. Problems with sleep, and we'll have an entire talk with Dr. Valerio about that, and so I'm not going to say anything more about that other than that I think this is really, really basic. And if any of us misses a good night's sleep, we know what we feel like the next day. Imagine doing that for a week. You feel pretty rotten and irritable, and your concentration goes down, and if you keep doing that year in, year out, it'll have a profound effect. So sleep is really important, and I'm very happy that there's an entire talk dedicated to that. Fatigue is very common. I'll get back to that and how it differs from sleepiness. Pain can affect many people. Problems with mood, problems with anxiety, apathy, even psychosis or hallucinations or the forerunners of that, and frank psychosis at times. Depending on the medication, also some impulse control disorders, and then cognitive problems. Now, when I throw this big long list out, everybody sitting here is probably thinking, oh my gosh, this is, I got to face all of that. No, so let me be very clear here. This is something that can happen, but that does by no means say that all of these things will happen to one individual. But why we're going through that in the clinic, we're screening for all of these things, and why I want you to know about all of these things is that Parkinson's is different from person to person. It's a very individual disorder. And what might be true for you might not be true for the next person. The important bit is to recognize it, to understand it as part of Parkinson's, and then to also bring it up in the consultation so that we can address it. So just briefly, how is it diagnosed? It is a clinical diagnosis. That still holds true 200 years after its first description. Any other tests we order are really complementary and or to exclude other disorders, but if you've got a very clear classic history, the diagnosis is made on clinical grounds. And now, also as a bit of background, how does this all start? We think that for a majority of people, maybe not everybody, but for a majority of people, the problems in the cell without having necessarily symptoms yet probably start in the gut or maybe also through the nose. And the reason why we're saying that or why we're believing that now is on clinical grounds, constipation can occur decades before any motor symptoms occur. So people who've got a reduced frequency of bowel movements in their 40s are at higher risk of developing Parkinson's disease in older age. So there seems to be something going on for a long time. Similar loss of sense of smell or reduced sense of smell, the individual might not always notice that, but the partner often does. And that also would originate in the nose, of course, an area where there is direct contact to the environment, and the same goes for the gut. So, things that come in through the gut. Both of these surfaces are, of course, also heavily inhabited by microbes, bacteria, viruses, fungi, etc., which is why there is such a surge in, or really the beginnings of interest in these microbiome populations, and to see how they might play a role in Parkinson's disease. Also then, of course, the interplay with nutrition, which we'll hear more about from Dr. Mischli later on. And so that is where we're focusing. And when you look at pathology and cells, the nervous cells of the gut, you can see changes that are very similar to the ones that we can see in the brain in Parkinson's disease very early on in the gut, earlier than in the brain in many cases. Now, things aren't always black and white, so this doesn't apply to 100% of people, which is why it is so much more difficult to study these things. But this seems to be a concept that is holding some water and is certainly worth following up on. So what happens in the cell? So I'll keep that very short, but essentially there are several mechanisms where things can go wrong in the cell. And one of them seems to be, frankly, a recycling problem. So proteins that are used in the cell then get sorted into recycling or reuse or just simply trash, so they're being destroyed and then getting rid of. And that particular process does not seem to be working all that well, and you've got a buildup of proteins, particularly alpha-synuclein as kind of the core protein, and these, what we can call Lewy bodies, those are protein accumulations inside the cells. And then they clog up the system. It's like, you know, the garbage not being collected, and you know what the back lane looks like. Inflammation plays a role, oxidative stress plays a role, energy production plays a role. So these are all cellular mechanisms that are being followed up on, and also followed up on for potential treatments, of course, and that is the important bit for you, that, you know, researchers are busy working on all of these pathways to find new treatments. So what about those dopamine-producing cells? You know, so far I've spoken about the gut and the nose, but where does the dopamine come in? The key symptoms that we see in Parkinson's disease, which are these motor symptoms, they stem mostly from a problem with the dopamine-producing cells, which are these dark ones here. And if you lose them, and then it looks much paler. This is the substantia nigra here, and there we go. Here is another view of the brain. So when you cut the brain like this, and now you're looking at it lengthwise, you see the substantia nigra here and here. And then it projects to various parts of the brain. Excuse me. So here's the substantia nigra again. And from there, it then projects to both the motor centers of the brain, as well as the higher thinking, the cortical centers, emotional centers. So dopamine is actually really crucial for the motor symptoms, as we already saw, but it is also crucial for things like reward. So for learning, you know, if you're looking forward to a really nice slice of chocolate cake, that would do it for me. And that is when your dopamine gets going. That is this, you know, in this case, it's the anticipation of a reward. And that when that goes, you just don't feel the joy anymore, you know, and you might also not taste the cake, but you just don't feel that joy. And it's really important to guide our behavior to have that reward, that feedback from the brain. What you just did is good. Learning is really important, and then placebo effect as well. That's important in Parkinson's, because if you take a placebo, so a sugar pill that doesn't actually have the active ingredient, you can still get dopamine release, and you can still get an improvement in symptoms. So having said all of that, setting the stage for the practical bits, the stuff that we actually do in clinic, the stuff that we talk about, the stuff that decides on how your day goes, really. So I will start with the team that should be around you, and the core team, and I can't read it from here, which is why I wanted to move this thing. So there is you and your family. Obviously, you should have a family doctor. Anybody who doesn't have a family doctor, I know they're short, but that is definitely a person to have. The neurologist, and if you have a movement disorder specialist, I'm of course biased towards that it is a good idea, and we try to train more people so we have more movement disorder neurologists. Fortunately, they don't grow on trees. It is a very long road to becoming a movement disorder neurologist, but we're working very actively in getting more of those people. And then physiotherapy, nursing, depending on your symptoms, a range of other medical specialists, of course, the Parkinson's Society, pharmacist, occupational therapist, etc. And counselor was already mentioned. So ideally, you should assemble this whole team around you and your family. And that is why you and your family is in the middle here, because Parkinson's is a family affair. It always affects the people around them as well. It is not just an individual problem, but it is a problem. It's a team problem. So when you see your physician, particularly neurologist, movement disorder specialist, how do you get the most of your consultation? So by doing what you're doing right now, becoming an expert for Parkinson's disease, the people who are actively engaged, who face the challenges, who get the knowledge, they are doing better. And so by doing what you're doing right now, you're doing the right thing because you become knowledgeable, and I'm sure this is not the first time that you're doing this. Important, of course, to know about motor and non-motor symptoms. And before a clinical appointment, what you could do, and part of that is having the actual piece of paper, part of that is also just focusing your mind on the problems that are there. So you can write down on one page. Don't write more than one page because there's just simply no time to read it in the clinic. One page, though, can be very useful. To write down what medications you're taking and when. And this is not what your doctor said you should do, but this is what you're actually doing, because that is what your symptoms are based on. And we often have that conversation. Yeah, okay, I should take medication, and I know this is taxing at 7, 11, and 3, and 7, and so on. But actually, I'm taking it at 7, and then the 11 dose might go, and then there are problems over lunchtime. So write down what is actually happening. You know, it is for sure difficult to take that many medications, to think about it, to fit it into their day, no question. But you'll get so much more out of the consultation when we can talk about what is actually happening and not what should be happening. So that is one. The other one is which of those symptoms, the long list of symptoms that are listed, are actually affecting you, and which ones are the ones that are troublesome for you. What is the priority you have? What is the most important thing that we need to address? And we'll look at everything else as well, but it's important to know what is most important to you. And then, of course, the timing of the symptoms. So how does the timing of the symptoms relate to when you're taking the medication? And we'll see with wearing off and dyskinesias how this is really important and crucial in making these decisions. Be open about particularly those non-motor symptoms. So depression is, of course, one, or apathy, hallucinations, impulse control disorders, sexual dysfunction, any of these things that nobody really likes to talk about. Be open, because then we can do something about it. Difficult if we don't know. And as I mentioned before, it's a family affair, and we always very much welcome family members, friends to come to the consultation. So you make that decision who's coming with you, but it's always a good idea to have somebody come with you. So what are the principles of treatment? So medications are really used at the minimal effective basis. So we don't want to go overboard, but we want to give you enough to really maintain your best possible function. We want you to be active. We want you to be exercising, participate in social activities. That is really the gauge that we're using, you being active. And that is exercise and other activities are really what will have an impact on how you're doing with the Parkinson's. So that also means, when should I start medication? And I usually say, well, start medication when you find that you're not able to exercise as much anymore as you used to. So it should enable you to do physical activity. Exercise has likely an effect on neuroprotection. It is not completely proven yet, but I think there are enough smoking guns pointing that direction. So exercise is really, really important. There is no good evidence that delaying treatment is helping you in any way. Rather, and that is what more recent and large studies have borne out, not treating, delaying treatment despite symptoms that have an impact on function, delaying treatment is actually a lost opportunity, because if you don't use it, you'll lose it. So really keep practicing, and I know they're on the internet. Anything that was posted on the internet at any time will be there for forever, so you will find a lot of things still about medication phobias. And yes, of course, any medication has potential side effects, but not treating Parkinson's when function is affected is really a lost opportunity. Now, in terms of, and I already said, so when symptoms interfere with everyday activities, that's the time to adjust or start medication. So now an overview, and I have to say, I would like to move this whole thing. I just have to move those a bit closer. So levodopa is really the gold standard of medication. Levodopa is what we've got in our own brains, and levodopa then becomes dopamine in our brains. This is, as we know, what is missing in Parkinson's, amongst other neurotransmitters, but that's the main one we're focusing our treatment on. And So what happens is that you're really replacing the missing substance. It's not an alien substance to our bodies. It's like somebody with diabetes and you're replacing insulin. So it is the gold standard. And the carbidopa part, because it's always levodopa, carbidopa, the two together, the carbidopa is only to prevent side effects. And that is important because otherwise you'd feel very nauseated. You know, you only want the levodopa to be converted into the active dopamine in the brain, not outside in the body, because otherwise you get side effects. Then there are dopamine agonists. So those are the things like, you know, pramipexole, ropinirole, the reticulothymine patch, bromocriptine, still in this province. And they mimic dopamine. They go to the same receptors. They're maybe not quite as strong as the levodopa in their effect, but they last longer, and that can be a real benefit for certain conditions. Then there are COMT inhibitors and MAO-B inhibitors. Both of those really act to prolong the action of dopamine. So instead of the dopamine being cleared and degraded, it just hangs around for longer and you get more bang for your buck, so to speak. Mantidine is mostly used to treat dyskinesias. In earlier times, it was also occasionally used as a sole therapy in the beginning. Some people still do that, but that is less the case now. And which medication should you start with? Many of you probably are, have done that already. There will be very few people who are just making this decision right now. So levodopa gets the best motor benefit if excellent motor control is the objective, such as somebody who's, let's say, a dentist and needs to have excellent motor control. That would be the treatment of choice. Of course, age and other didn't do anything. Other medications and other medical conditions play a role. The problems can be that it wears off, so it doesn't last long enough, particularly as time goes on, as well as dyskinesias, and I'll come back to those afterwards. Dopamine agonists would be another choice. They would be the second best in terms of motor benefit, but can certainly be very active and efficient, depending also on whether somebody has got other symptoms with that, such as restless leg syndromes, etc. Downside are potential impulse control disorders, so behaviors that are addiction-like, as well as sleep attacks. And then there's rasagiline and selegiline. Those are the MAO-B inhibitors, and they can be used as therapy on their own in the beginning as well. They have the least potent motor effect, but the advantage of the rasagiline is that you need to take it once a day. Might have some neuroprotective properties as well, but this is really not proven as such. So how do I deal? Now we're fast forwarding a bit and we've taken the medications for a while, and how do I deal with the potential problems that can come up? So motor complications. So what to do when the medication doesn't kick in? So one of the first things would be to look at whether you're taking protein in your diet together with the levodopa. It's a minority of people who are affected by that. In the beginning, it often doesn't matter anyway. But later on, if you find the lunchtime medication just doesn't kick in, and I'm always off early in the afternoon because the medication doesn't kick in, it might be because there's just more protein in your food, and it uses the same transport mechanism, essentially the same train as the levodopa, which is also a protein, and it just doesn't make it to the brain because the train is full and the small levodopa tablet doesn't get on. So taking it, some people say an hour away from protein or would make sense in that case. Other potential strategies would be if you're really off, let's say, or it's early in the morning and you need to get up now, medication doesn't kick in, you could take a half tablet of the yellow immediate release levodopa, crush that, mix that with an acidic or carbonated drink, so ginger ale, orange juice, etc., and swallow that mixture. It's often better than chewing it because when you're chewing it, it tends to stick to your teeth, although some people do that successfully as well. But with that crushing and mixing, it should kick in within 10 minutes or so. You can also take the medication when you're still lying in bed, then turn over, and half an hour later, when you're actually peeling yourself out of bed, the medication has hopefully kicked in. So that is another potential strategy. One really, really important bit, and I'll get back to that later, is to treat constipation. That is really key. The reason for that being is that otherwise, if everything kind of clogs up, there is no transport happening even from the stomach into the small intestine to the large intestine. And the tablet just kind of, you take the tablet and the tablet sits in the stomach where it sits rather well, is not being absorbed, doesn't do anything other than maybe giving you side effects, nausea. But the medication doesn't kick in. Medication needs to get into the small intestine, hence DOPAMINE being infused into the small intestine, not the stomach, in order to be actually absorbed. So make sure constipation is treated, and as I said, this is so important, I'll come back to that. Very rarely, on occasion, we test for that. A Helicobacter pylori infection can interfere with the absorption of the levodopa, and that's something that we can test for and can easily be treated with antibiotics. So what is wearing off? Is everybody, who's familiar with the term wearing off? So quite a few, but not everybody. And as I said, this is stuff we discuss in the clinic all the time. I think this is a really important concept to have. So what we're aiming for is good motor control for 24 hours. What actually happens is, of course, you take a tablet, levels go up, and we'll see that in the graph in a second, then they drop again, symptoms come back, and you're taking another tablet. And so what happens in practice is you take a tablet, say at 8, and you're due to take your next one at 12, but by 11, you're feeling motor symptoms coming back, so there might be some tremor, some stiffness, slowness coming back. So those are these motor wearing off here. Voice might become softer, posture more stooped. And then there can be non-motor wearing off, and the non-motor wearing off can actually occur even without any motor symptoms. Some people just tend to feel more anxious, or their thinking gets more clouded, or they start sweating, or they have to go to the washroom to pass water more often. So there are sometimes even isolated non-motor symptoms that can return at the end of a dose. Then you take your next tablet, you still have to wait because it doesn't kick in immediately, so you wait, let's say, half an hour, and finally your symptoms improve again. So that's wearing off, and that is where it is so important to note what the timing of your symptoms over the day is in relation to your medication. So there we go, again with the graph. So in the beginning, so early on in the disease, you take your medication, there's a huge green therapeutic window. So this is the concentration of the medication, and this is time here. So you take the medication, you're green the whole time. Symptom control is good. And then a bit later, what happens is that you take the medication, but you need actually a little bit more to get symptom control, to get into the green range. And there might be some overshooting. And in that overshooting, in this red area here, you can have essentially an overdosing dyskinesias. Now, the mechanisms behind the occurrence of these dyskinesias are very complex. They don't just, the plasma concentration that is plotted here is probably one of the lesser factors, but it also has to do with changes in the brain, with progression of the Parkinson's itself, with less cells, less dopamine cells there that can both produce as well as store and then release the dopamine in a timely and coordinated fashion. And that problem continues even further the more time goes on, in that it takes more to get to an on state. The on state is then a much narrower path, and you're more easily overshooting as well as sooner coming out of the therapeutic range. So in other words, you'll get dyskinesias here and then wearing off here again. So how do we deal with early wearing off? There's several different strategies, and it of course depends what you're doing at present and what you're actually doing, not what your doctor told you to do, but what is actually happening on the ground. So for example, if there is a gap of 5 hours between two dosages, it might well be that there's wearing off. And so in that case, one could bring the dosages closer together. So we'd aim for like 4 hours and then employ additional strategies, depending, of course, on the individual. You could use You could use the controlled release formulation. We do that often at night particularly, so controlled release before bedtime because you want to hopefully cover the night. You could add either entacapone or one of the MAO-B inhibitors, rasagiline or selegiline, to get more out of each dose of levodopa. You could add dopamine agonist, as I mentioned before. They go to the same receptors. They mimic the action of dopamine, but they stick and cling to the receptor for longer. You could use the, obviously constipation, etc., needs to be treated. That's something that we ask about and really emphasize all the time. You can use laxatives on a regular basis and of course nutrition, I'm sure we'll hear about that, is absolutely crucial for that. Exercise as well. And as I said, so there is a variety of different strategies. It is very much dependent on the individual, and you might combine or try different strategies. Now, in terms of dyskinesia, so I already mentioned dyskinesia. Who's familiar with the term dyskinesia? Good amount. Who knows the difference between peak dose and biphasic or wearing off dyskinesias? Very few, and that is actually quite important. So peak dose dyskinesias are the ones that I think most people know about. Those are the movements often affecting the upper body, but can be whole body again, with kind of snaky fluid involuntary movements that aren't rhythmical like a tremor, but that seem far more random. And they're like fidgety, writhing movements. And they can come in any amount of severity. They can be very mild to the point that you don't even recognize that they're there, but maybe the spouse comments. But they can also be really severe and disabling. Most people get the mild variety, and actually we see some severe ones, but actually not all that much anymore, I found. Biphasic dyskinesias occur when levodopa is just about to kick in, you're just getting into that green range, and we're just dropping out of that green range. They are somewhat different. They often affect the lower body, so the legs. They often are more of a cramping of the toes, so this toe curling in, the cramping early in the morning, that would be wearing off dyskinesia. It could be that the foot is turning in, or the legs are moving, even larger amplitude movements of the legs would often be wearing off dyskinesia, so with the upper body relatively unaffected. And the crucial bit here, apart from what it looks like and which body parts are affected, is the timing as well. So if you have dyskinesias and they occur when you're otherwise really on, meaning that there is little stiffness and you're moving fast, that is likely to be a peak dose dyskinesia occurring, let's say, an hour after you take your medication and then lasting until you're starting to wear off. If the dyskinesias come on at a time when you're just about to kick in and become on, and when you're just about to wear off, then this is more likely to be biphasic. There we go. We already talked about that. So you would get the peak dose dyskinesias here and the biphasic dyskinesias here at the kicking in and wearing off times, and then during the wearing off times. So the important bit, why we're differentiating that, is of course because they've got diametrically opposing treatment strategies, because one is too much, the other one is too little. So for peak dose, what we're trying to do is to get these overshooting peaks down. So we want the levels to be in the green range. So reducing the single dose of medication, but maybe giving it more often to, instead of having this as a curve, to have more that of a curve would be our goal. And that can be achieved with various strategies, similar to the wearing off as well. So we can reduce the amount of any single dose, take it more frequently, add a dopamine agonist, reduce the levodopa dose is a possibility, add amantadine, which can be useful for peak dose dyskinesias, duodopa, which Jean already referred to this morning, which is this infusion directly in the small intestine, can be useful for that as well. And then And tachypone often, unfortunately, drives dyskinesia. So at this point, if there are peak dose dyskinesias, we often actually even break the tachypone in half or remove it completely. Surgery, so deep brain stimulation can be very useful for that as well. But yeah, as we know, there's some problems with that right now in terms of accessing it here. And we talked about this. So the biphasic dyskinesias, it essentially indicates under medication. So what you want to do in this case is actually, boost the medication so you're back in the green range and that you're not dipping in and out to the bottom into the green range. You could, for example, change a controlled release medication to an immediate release medication so that it kicks in more reliably. Because it is like wearing off, you can use all the strategies you used that, for wearing off to prevent these biphasic dyskinesias as well. So coming to non-motor symptoms. So again, we looked at the whole range of different things. So there are sensory changes, including smell and taste and vision. There are autonomic problems, bladder and constipation and nausea and orthostatic hypotension, which is that your blood pressure drops when you're standing up. There can be sexual problems. It's important to mention as well in the consultation if that is something that is bothersome. Sleep problems we'll see about in the second talk. Pain and neuropsychiatric symptoms, fatigue, and we already went through depression, anxiety, apathy, impulse control disorders, etc. Obviously, it is impossible to talk about all of these things in one talk. I'll just pick out a few that I think are, that might be worth knowing about, but obviously there are others, and I don't know whether you get the slides. I guess so. There are slides on the other symptoms at the end of the talk that I'm not going to show right now. So again, non-motor symptoms, I'm passionate about them. They're very common. They have a huge effect on quality of life. They might be overlooked or taken for granted. So for example, low mood, yeah, well, of course, I've got a chronic disorder. But do not take it for granted and do not just accept it as part of Parkinson's that can't be dealt with. And because they can often be treated. So constipation, I'm mentioning this about for the third or fourth time now, because it is so important. For just well-being, but also, as I said, for the medication to actually be absorbed. There are X-rays and CT scans of people's abdomens, and you see these little oval white things in there. And it is the pills that are still lying in there because they just never made it out of the gut. So treat constipation, really, really important. And it's very, very common. There's the practical bit, so we'll hear about the nutrition, but make sure you're drinking enough fluids. And often I hear, yes, that's all good and well, but then I get more bladder problems when I drink more fluids. And yes, I see that problem. On the other hand, if your abdomen and the pressure in your tummy is higher because there's so much in there, it'll also push on the bladder, so that in itself will make bladder symptoms worse. So it is worth treating the constipation. And of course, for getting all that fluid in, you could try and do most of that earlier in the day and maybe not just before you're going to bed, so that the night is a bit more restful. Exercise is really important, including, of course, core muscles, so do tummy crunches, etc. Stool softeners can be used, and they can also be combined. There are different mechanisms of action. Laxatives such as polyethylene glycol, which kind of draws water into the gut and thus making it bulkier but also softer, can be very useful. If you ever have a week without a bowel movement, or you're feeling uncomfortable because of it, and you haven't had a bowel movement in a few days, do seek medical attention, because that can have more serious side effects as well. Yeah, I think that is pretty much that about constipation. Now, Another one that comes up often is postural hypotension. So this dizziness, you're standing up quickly, and then you actually have to put your head down because you're feeling all dizzy and as if everything is closing in on you. Worst case scenario is that somebody passes out. Fortunately, with Parkinson's itself, that is very rare. We see that with other disorders such as multiple system atrophy much more frequently and earlier, but it happens in Parkinson's as well in a milder form. Sometimes people get head and neck pain and shoulder pain, like a coat hanger pain on standing up. That could be an expression of that as well. And new studies also show that even if the drop in blood pressure that we can measure in the clinic doesn't lead to overt, obvious symptoms, it can still increase your risk of falls. So it's an important one to treat if it is a problem. The underlying issue is both the Parkinson's itself. It wouldn't occur without the Parkinson's, as well as the medication. Both dopamine, so levodopa, as well as the dopamine agonist can contribute to that, and they can make that postural hypotension worse. So what to do? Stand up slowly, move around before you stand up. You can elevate the head of the bed at nighttime, because the flatter you lie, the less work there is to do for your heart, and your blood pressure will go up. And then it's up during the night, and your system thinks, excellent, we've got fantastic blood pressure, we can get rid of some volume. In other words, you're peeing water out. The next morning you're trying to stand up, and then the water is gone, and the blood pressure sinks even lower. So that is why sleeping with the head of the bed elevated by like 30 degrees or so can be helpful in that way. Obviously, drink sufficient fluids. Some people use these electrolyte kind of sports fluid like Gatorade, etc. Other people just put salt into water and drink that. You can have a small coffee with your meals. Make meals small, so more smaller meals rather than 3 large meals, because otherwise you've got all the blood pooling in your stomach, busy with absorbing, and that doesn't help your brain. Avoid alcohol or high heat. So the sauna, unfortunately, as much as I like it, would not be the best place to be, or the hot tub, because that would make the problem worse. And we talked about the increase in salt intake. Not very popular, but generally helpful would be compression stockings or abdominal binders, so compression around the abdomen. But I know that they're a pain to get on and off, and so I put it out there. But few people actually think this is going to be really practical. For more severe problems with this drop in blood pressure, we have several medications that we can use, and use either in combination or on their own. And of course, that is really important. Avoid medications that lower your blood pressure. So many people have high blood pressure for many years, then they get Parkinson's, and the blood pressure actually goes down. And it is important to not just keep taking what you've been taking for years just because you were taking it. Often you can get rid, and there must be some upside to this whole Parkinson's thing, you can get rid of some of the high blood pressure medications because you just simply don't need them anymore. Fatigue. That is something that many, many people experience, and it's this feeling of the whole body give out, the feeling you've just run a marathon, you're now completely exhausted. It is not sleepiness that I'm talking about. Of course, you haven't run a marathon, but you feel like it. And even a relatively short activity will leave you like that. It is not sleepiness that's different and will be covered in the next talk. It's not the kind of eye-closing problem. But fatigue is very common, and it's actually a tricky one to treat. And despite now some emerging research, there hasn't been all that much on it, but there is some research. It is not entirely clear what causes it. It seems that, as with so many things, there seem to be several factors that can play into that. Some of that might indeed be responsive to dopamine. So sometimes it can just be a symptom of wearing off, and it improves with increasing the dopamine medication, or treating wearing off symptoms. Sometimes it can help to just have a nap after lunch, for example, and you wake up and you're restored, so make sure you're taking breaks in between. I have to say very loud and clearly, it is not moral weakness, and it has a significant impact on quality of life. There is some overlap with depression, with anxiety, with apathy, and of course with sleep problems, and that is part of the art of treating that, is to try and figure out which of those other factors are associated with it, because we could, for example, treat depression and would make fatigue better. We can treat sleep problems and make fatigue better. So what to do? As mentioned, wearing off needs to be treated, pacing activities, planning breaks. Sometimes, particularly if it's wearing off under medication, it improves with an increase in medication. There are some medications such as amantadine, rasagiline, selegiline that seem to have some positive effect in some people as well. So depending on your situation, that might be worth trying. Graduated exercise is important. So don't stop the exercise because you're feeling fatigued. It's actually, particularly in that situation, important to keep going. You're not going to start with a marathon, but have planned activities, set yourself a time. You can increase that over time, and that actually does have evidence to be helpful. Testosterone dopamine agonists don't seem to be doing much. Pain. Yes, that can be due to Parkinson's. So the intensity with which pain is felt can be increased with Parkinson's, particularly if you're wearing off, there can be a problem. But of course, if you've got, let's say, a joint problem, and joint problems are incredibly common in the general population. As we all get older, joint problems are everywhere. But if you now have an already angry joint and you got muscles that are stiff around it, that's just going to make this joint even angrier. So important to, again, treat both. And it might not be, so we'll optimize the Parkinson's medication, but then also make sure you're going to the GP and treating the joint problems. And if the pain is mainly present towards the end of a dose, we'll treat the wearing off, right? Sometimes physical measurements, such as putting a warm pack onto your shoulder or taking a warm bath, massage, stretches, that can help, and having a set of stretches that you do every day is certainly a good idea. So speak to your physiotherapy, and if it is wearing off related, that's what we treat. Pain medication can be useful. The principle behind that would be not to chase the pain, but if there is chronic pain, to treat it with a regular pain medication schedule. Now, depression, anxiety, and apathy. Now, these are the dark clouds. Essentially, depression is you're not able to enjoy the activities that you once enjoyed. There's a lack of energy and motivation. Anxiety often comes with depression. It leads to increased worrying, often lying awake at night and then thinking about all the things that might happen in the future. It can lead to panic attacks as well. Often people say, things that I used to be very relaxed about, like being on time for an appointment, traveling, etc., now really make me feel anxious. And I got to leave much earlier because I just need to be there on time, because otherwise I feel too anxious. It can occur before any motor symptoms of Parkinson's, so it can be one of those early symptoms. And it can be due to Parkinson's itself, or it can be due to the reaction to the diagnosis. That's very common. So what to do? Important to have a good social network, family, friends, people that you can talk to, and continue being active. Really important. Volunteering can, for example, be a very good thing in that regard as well. Being socially and physically active, so exercise can be useful in that regard. If it is associated, particularly anxiety or low mood or irritability, with wearing off, we'll treat the wearing off again. Counseling, unfortunately, the BC Parkinson's Society provides that as well, and I'm sure we'll hear more about mindfulness later on, can be very useful as well. And then there are medications as well that we can use. Hallucinations, I'm going through this a bit quicker now because I see we've got about 10 minutes or so left. Hallucinations, so that could be anything from, very mild part would be a feeling of shadows moving in the corner of your eye, or feeling there's somebody in the room with you and you turn around and there's nobody there. But it could also be what we call illusions, where you mistake an object, let's say a fire hydrant, for a cat or a dog or a little person, or seeing faces in clouds. And then if it is more pronounced, it would be to actually see, let's say, a person or animals when there is actually nobody there. It can be mild and with complete insight, and this is what is happening, but it can also become more of a problem over time. It's always worth mentioning that to your physician, because it does guide us a little bit as to how aggressively we increase medication, for example. Because the problems with hallucinations, or with even beliefs that aren't true, is that it happens because of the Parkinson's. It's the underlying Parkinson's that drives those, but it is certainly made worse by any dopaminergic medication. And you might remember this diagram that I showed you in the beginning, where you see all these different paths that dopamine can take in the brain. And one of them is for motor control, but there are other paths as well that control our thinking. And that is when you suddenly overdose those paths, they start thinking on their own, they become overly active, and that is when you can see things that aren't there. What to do? As mentioned, talk to your team, that's really important. We would at this point usually reduce and simplify Parkinson's medications. So dopamine agonists would have to go, amantadine has to go, entacapone, rasagiline. They would likely, depending on the severity of the problem, we would likely reduce those and try to manage things with levodopa particularly, because that is the one that has the least of those side effects. There are medications we can use called antipsychotics, quetiapine and clozapine. Low dose, no other neuroleptics. So sometimes we see that in the hospital. It's one of the big problems. Somebody is admitted to hospital with advanced Parkinson's often. First of all, they might not get their medication on time, but then they have, let's say, a surgery, and one gets confused in hospital. There's some confusion, and then what we call a typical neuroleptic, other than quetiapine and clozapine, are used, and that then makes the Parkinson's symptoms so much worse. So when you go to hospital, there is the package now. What is this called again, Jean?
Aware in Care. We don't quite have that ready yet, but it will be important.
It will come. So I'm putting a plug in for this now, that, bring that to the hospital so people know what to do who are not familiar with how to treat Parkinson's. So no other neuroleptics for this problem other than quetiapine and clozapine. And there's a new medication now that works on a completely different mechanism, pimavanserin, that is now approved in the United States, but not quite in Canada yet. But I think eventually we'll get it here too. The other part of that is our medications that can treat cognitive problems, so rivastigmine, donepezil, and they can also improve hallucinations should they be there. Impulse control disorders, I'll briefly touch on that. They are mainly a problem with dopamine agonists or exceedingly high dosages of dopamine. Some people, it's a minority, it's like 1% to 3% of people, so it really is a minority. But some people develop this addiction-like behavior towards their medications, and an impulse control disorder is anything that you do over and over again, that you find difficult to stop, that you do at the expense of other activities, such as seeing friends, spending time with family, doing other hobbies, meals, etc., that you find really irritating when somebody tries to stop you from it. And that often doesn't lead to all that many productive outcomes. For some people it does, and they're very productive, often in artistic endeavors, but for many people they might produce an enormous amount of spreadsheets that don't ever quite finish. So if anything like that happens, and particularly if anything like gambling, compulsive shopping that can have a very detrimental effect on family life, finances, etc. happens, talk to your team. And it is really, really, really important for the families to be aware of that, because when you're doing it yourself, dopamine is related to reward behavior. These symptoms occur as an over-medication of these reward circuits. So you actually feel quite pleased with what is happening. It's actually going to be really nice. The problem is that it still leads to problems. And that is where the family members come in. The family members need to be aware of these potential side effects of particularly the dopamine agonists, which is why we're using them way less now than we used them in the past. And step in as soon as they're the first signs of it. You know, there's a bit of a slippery slope. Having said that, dopamine agonists can also help with apathy because they give that reward. So a little bit of it is a good thing, but you just got to be careful not to go overboard with it. Yeah, and in that, you know, you really got to talk to the team. We'll try and reduce or discontinue the offending medication. And there are several other things that can happen. Cognitive difficulties, they're actually fairly common, and they can be very mild, and they can just be normal aging and, you know, forgetting something. Even she was 6 years old at the time that happened. She said, "Mama, sometimes I go to my room and then I'm there and I don't know why I came." So it happens for young people as well, clearly. It can happen to all of us, but if it is if it becomes more of a problem, particularly if things like planning things, doing things in a certain sequence, maybe learning new things is affected, it's always a good idea to talk to your team. If it's difficult to organize your medication, if you don't know whether you've taken it already, and if you get muddled up with the different types of medication, definitely get help. So with that, what do we do? Very important to stay social and mentally active, of course. There are certain medications we can use. Exercise can be helpful as well. Important, again, to have a team approach because the partner might need to take over a few of these activities. And we generally, at this point, would simplify, again, the Parkinson's motor medication, so the medication, the dopaminergic medication. And that brings me to the last few slides on exercise. So the other basics are pretty much covered. So sleep, nutrition, mindful living, by the other talks. And I'm, as you already heard, really pleased about that. I'll put a little bit in on exercise here. I would say it's the new job. Exercise has many different pluses and benefits in anybody, not just with Parkinson's, but in Parkinson's particularly. If you are very active in middle-aged life, you reduce your chances of Parkinson's later on. Exercise in people who already have Parkinson's increases longevity. The introduction of levodopa in the 60s also increased life expectancy in people with Parkinson's, and this was probably also partially, at least, because of all the exercise that could be done. And there's some indirect evidence and evidence in animal models that suggests that it also has a positive effect on actually slowing disease progression down. And in the clinic, I just cannot say it loud enough, the people who take exercise seriously and who do the exercise, they just do better. It's absolutely obvious. Fitness goes up means better cognitive scores, better motor scores. Even a single bout of exercise, we did a study on that, can have immediate effects on both motor functions as well as cognitive functions and mood. And as I said, it might potentially increase neuroplasticity as well. It can, as I mentioned before, also improve fatigue and quality of life. And what are you going to do in practice? So ideally, you want to have a combination of different exercises. The research is still ongoing as to whether there's any single kind that is more effective than others. But in the meantime, I would suggest to have a combination. Aerobic exercise has a lot of research to support it. So anything that brings your heart rate up, that makes you sweat. Obviously, if there are any other medical conditions that you're concerned about, then you get clearance from your doctor. But generally speaking, most people should really aim for aerobic exercise. Strengthening exercises can be very helpful. Stretching, balancing exercises. And then it could be anything from dancing to cycling to walking. Boxing has been very popular and with many people recently. Yoga, Tai Chi, Aquafit. Really, the most important thing is that you enjoy it, because otherwise you're not going to do it. So you need to find something you enjoy. Ideally do it with a partner or in a group, because you've got a date. You can't skip that. You can't turn over in bed and say, maybe tomorrow, and today it is raining. Which brings me to the West Wet Coast special, which is get good rain gear. Makes a big difference. Anybody with a dog who has to go out by rain or shine will know that as well. Good rain gear just makes you feel so much better. And I had a conversation yesterday in clinic about exercise. Do you do regular exercise? Yes. What do you do? Walking. So how often do you do that? Well, I do it in the summer when the sun shines. We just had a rain record for October, which was, I think, 26 or 28 out of 31 days with rain here. So that's just not going to fly. You got to get rain gear or do something indoors. Important to exercise when you're on. So take your medication before you're exercising. Some people need an extra dose of medication or something in between to make sure you're exercising at your best level. And obviously drink sufficient fluids, gradual increase in intensity, so don't run that marathon, from couch to marathon. Keep an exercise diary can be quite rewarding. And doing something nice afterwards, apart from feeling good from the exercise, having a nice coffee or so can be very nice as well. So my last 2 slides on this, and then I'm finished. Very briefly, what is on the horizon? And this is just it's my kind of subjective collection of things. As already mentioned, there is more and more research into the basics, such as exercise, such as nutrition, and other self-empowering methods that are really life skills, such as mindful living. This is coming out more and more, and I can't say it loud enough. I think, we evolved as human beings over millions of years with these things. That was always part of our life, and that is what we need. Without that, we're just not going to do well. So these things need to be covered, and they go a long way in making life better. What else is on the horizon? Some are a bit closer, some are a bit further. So new delivery methods of levodopa, anything from under the tongue to inhale to a self-administered injection, so into the subcutaneous fat tissue. Things such as DUODOPA, of course, have been around for quite a few years, particularly in Europe, and are hopefully now more and more coming to British Columbia, and thanks to the Parkinson's Society. Hopefully we'll get that covered more broadly here as well. Medications targeting other neurotransmitters other than dopamine are being looked at. Medications that are looking at alleviating this oxidative stress, alleviating neuroinflammation, etc., are being looked at. Other proteins, we talked about the recycling problems in the cell, are being targeted. So that would, for example, be a direct effect of research into genes that are known to cause Parkinson's. Other things are these immune-based therapies, so vaccinations, active and passive vaccinations against alpha-synuclein being developed, brain stimulation with external brain stimulation as well as deep brain advances in deep brain stimulation. Stem cells mostly for dopamine delivery, and let me just say, anybody who offers stem cells right now, anything you have to pay for, anything that is out of the research realm, do not do at present. Like, it's a big no. There's certainly a lot of placebo effect in that, and as mentioned, that leads to dopamine release, so you will feel better. Your wallet won't, but there are potential severe side effects. And it really is not in the clinical realm yet. It's very useful research, and I hope that we'll get there someday, but right now it isn't. And there's much more. It really is, anybody who's been at the World Parkinson's Congress recently, and I saw a few people sitting kind of here-ish, where I think you share my sentiment that there's really an enormous breadth of activity happening. And just briefly, at the Pacific Parkinson's Research Center, we obviously have a lot of different research programs as well. We can only do it with people participating, and I put a plug in here for also healthy volunteers, because we can't do the research without having people who do not have Parkinson's, because we always need to compare it to people who do not have Parkinson's. And with that, I'll just leave you with my take-home message, which is become an expert for Parkinson's. You're already achieving that. That is really good. Know about motor and non-motor symptoms and be open about them, talk about them in the clinic. before clinic appointment, just either mentally or on one page of paper, write down what are the main symptoms, what is really bothering you, when do they occur, and what do I actually, how do I take my medication? When do I actually take it? And we talked about the be open and then mind the basics. Sleep, exercise, nutrition, being socially and mentally active, and living a mindful life. And you can do a lot yourself to improve quality of life that way. And that was it.